Good day, these great surgeons. Today we're gonna talk about a very important yet crucial topic, which is the abdominal wall and GIT surgeries. Very important topic for all general surgeons and for MRCS exam. So let's have a ride through this important topic. In voice shots, we will combine it and make it easy as much as possible, especially if you are not a general surgeon.
Hernia is a protrusion of a viscous through a defect. Again, hernia is a protrusion of a viscous through a defect. Any organ in our body can be herniated. Any organ can be herniated. Except for the pancreas, because it's retroperitoneal, hardly to be herniated. Even the brain can be herniated through the foramen magnum, but the pancreas is harder to be herniated. So hernia is a protrusion of an organ through a cavity. To define a hernia, there will be a defect and a sac and the organ. The defect and a sac and the organ. So if we have, for example, an inguinal hernia, we have either direct inguinal hernia or indirect inguinal hernia. If indirect inguinal hernia, we are talking about the internal ring where there is a peritoneal sac and the organ, the visceral organ, will be the herniated viscous. So the defect, the sac, and the herniated organ. Regarding the diaphragmatic hernia, we have three types, mainly Bogdalic, Morgagni, and the hiatal hernia. Those are herniations through the diaphragm. Bogdalic hernia is the most common congenital diaphragmatic hernia. It's 85% of the cases, which are located in the left hemidiaphragm. Again, 85% of the Bogdalic in the back, on the left side of the diaphragm. It will be associated with lung hypoplasia on the affected side, and more common in male, and associated with other birth defect, may contain stomach even. It might be treated directly anatomical position or placement of a mesh, the infant, but this is after preparing the patient, resuscitation the patient. It's more important to treat the patient rather to treat the defect. The patient, that small child, will be born with Bogdalic hernia with a defect in the diaphragm, in the posterior wall of the diaphragm. You have to treat him well and prepare his weight and prepare him for resuscitation. You can't reduce all the intestine back to the abdomen without preparing the abdomen to be inflated again with viscous. The lung will be already hypoplasia. You have to deflate the lung again. Morgagni hernia is a rare type of diaphragmatic hernia, herniation through the foramen of Morgagni in the diaphragm. It's more common on the right side. Remember, the Bogdalic was posterior and on the left hemidiaphragm, but Morgagni on the right hemidiaphragm and anterior, and it might contain the transverse colon, and very, very common MCQ question. The defect is small, so pulmonary hypoplasia is less common than Bogdalic hernia, and direct anatomical repair is performed in Morgagni hernia. Remember, umbilical hernia in children, it's herniation through a weak umbilicus, and usually present in childhood, often symptomatic. You will find a protrusion of the viscous like swelling through the umbilicus of the child, the newborn, and 90% of the child will resolve by themselves by the age of 2. So there is no intervention in the umbilical hernia, in the congenital umbilical hernia. There is no intervention until age of 2. It will resolve by itself, except if it's more than 2 centimeters. Surgically performed after the third birth. Clinically, you can differentiate between the umbilical and the para-umbilical hernia through the sign of the crescent shape of the para-umbilical hernia. The para-umbilical hernia will have a crescent-like shape shadow, while the umbilical hernia will take the whole circumference of the umbilicus. So, the congenital umbilical hernia is a weakness through the umbilicus, while the para-umbilical hernia is a defect in the linea alba itself. There is a very famous terms for many types of hernias, like lateral hernia, amend hernia, Richter hernia. You have to be familiar with those hernias for the MCQ shots. Lateral hernia is the herniation which contain Meckel diverticulum. So when you find Meckel diverticulum in your hernia, it will be lateral hernia. And there is a very famous rare type of hernia called amend hernia. The amend hernia, when you find the appendix in the hernia, in the herniated viscus. By the way, you can't clinically differentiate between lateral hernia or amend hernia or the normal inguinal hernia you are familiar with. It's an intraoperative finding. You can't decide it's either Meckel or appendix just from any sign of toxicity even. It will be an intraoperative finding. Take care. Very famous type of hernia is a Richter hernia, when a part of the wall of the intestine, not the whole circumference, but a part of the wall of the intestine will become trapped in the defect. This is called Richter's hernia. By the way, it's a clinically very deceiving hernia type and requires a very intelligent doctor and intelligent surgeon to elide the sign and know this is a Richter hernia. You can find it clinically, and the patient will be relieved and in pain. And when you do X-ray erect, there will be no air fluid level. There will be no signs of obstruction. Even the patient will be toxic and vomiting and maybe up to diarrhea because it's becoming ischemic. The part of the wall will be ischemic from this compression over the part of the wall of the intestine. So take care of this type of hernia, the Richter's hernia. It will be on the anti-mesenteric border and the lumen intact with no obstruction, but it will be very painful and will be ischemic and may rupture. The Pantalon hernia, when you find two defects with two organs or even one organ in two defects, like the direct and indirect hernias. The sliding hernia on contrary, when you find two organs in one defect, so two defect equal Pantalon. Two organs in one defect is the sliding hernia. Meckel's diverticulitis. It's due to inflammation of Meckel's diverticulum, which is congenital anomaly that present in about 2% of the population and typically 2 feet up, proximal to the ileocecal junction and the ileocecal valve, and may be lined with ectopic gastric mucosal tissue and produce bleeding. When you are performing appendectomy and you find that the appendix is normal, you have to search for the Meckel's diverticulitis and the Meckel's diverticulum. And in female, if you found that the appendix is normal, search for the other genitalia like the ovary and the fallopian tube and even Meckel's diverticulum. So that's why laparoscopy is advised in females more than males, and as a rule for appendectomy. Laparoscopy is best because you can see with your eyes, while in appendectomy, in open appendectomy, it's a very short incision, and if you exceeded the limit of this incision and widened your incision, it will be awful for the patient itself. So laparoscopy is a rule. From practice and evidence-based, in acute appendicitis, if the patient is anorexic and doesn't want to eat, so it's appendicitis. If the patient is hungry and want to eat, it will not be appendicitis. So take care. Anorexia is a very characteristic sign with the toxicity of the appendicitis. There is a big difference between profuse vomiting and vomiting. In appendicitis, the patient might vomit once or two, but will not be profuse vomiting. Profuse vomiting is more common with gastroenteritis or ileus, but appendicitis will be vomiting, just vomiting once or twice. Okay? Umbilical hernia. It's intraparietal hernia occur at the level of the arcuate line, and it's very rare type, but you have to be aware of, because rare doesn't mean it doesn't come. May lie beneath internal oblique muscle, usually between the internal and external oblique. It has equal sex distribution for the MCQ. It has equal sex distribution, and position is lateral to the rectus abdominis, and this is the key. It will be positioned lateral to the rectus abdominis. This is the key in the exam and in life. Both open and laparoscopic repair are possible. It's important to differentiate between the normal constipation and the absolute constipation. Normal human will pass gas as much as he needs along the day, and it's a normal, happy thing for the surgeon. Yes, it's awful for the patient, but it's happy for the patient, for the surgeon, to know that his patient is passing flatus, at least, because absolute constipation is a bad sign. Absolute constipation when the patient is not able to pass either flatus or feces along the day for consecutive 3 days. This will raise the alarm to, yes, intestinal obstruction, and it's a very serious problem. Fistula. Fistula is not defined to a certain place in our body, because it's an abnormal connection between two epithelial surfaces, wherever it be, in the abdomen, the arm, in the limb, even the face. Fistula is abnormal connection between two epithelial surfaces. Fistula may be acquired or congenital, so take care. Fistula might be acquired or congenital. The surgeon decided to differentiate between the fistula according to its output. If it's high output fistula, when it's getting for you more than 500 milli per day or 25 milli per day, this will be low output fistula. If your fistula is getting to you fluids less than 250 milli per day, it will spontaneously close, and don't trouble the trouble until the trouble troubles you. So the fistula with high output will require intervention, but you have to wait. If it's going to be a low output fistula and giving you below 250 milli per day, it will heal spontaneously, wherever it be. By the way, treating the fistula improperly will cause its recurrence. If you didn't take the whole track of the fistula, if you are going to manage it surgically, it will open again in another opening. Inflammatory ulcerative colitis. Again, inflammatory ulcerative colitis. Why it's being used to have end ileostomy? Because in inflammatory ulcerative colitis, a subtotal colectomy will be done, and this will involve the entire right intertransverse and the left and a part of the sigmoid colon. Again, if the whole colon except for part of the sigmoid colon will be left, because the right and the transverse and the left and the part of the sigmoid will be all removed in the subtotal colectomy in the fulminant ulcerative colitis. So what will be there? The ileum and the part of the sigmoid colon. The part of the sigmoid colon will be closed, and the ileum will have its end. So this man have to make feces. So this end is attached to the skin through a hole, through a cavity. So it's end ileostomy. The end ileum, the end ileostomy will be brought up through a cavity in the abdominal wall for this patient to can defecate. Later on, we might attach the ileum to the part of the sigmoid colon, or just make it a long-lasting definitive in the ileostomy according to his general condition. Remember, in ulcerative colitis, we have two situations. It's either the elective case or the fulminant emergency case. In fulminant ulcerative colitis, you will be doing subtotal colectomy. It's an emergency situation, and subtotal colectomy will involve removal of the entire right colon, transverse colon, left colon, and part of the sigmoid colon, and will end with endoileostomy. There is no place in emergency for resection anastomosis. This will be subtotal colectomy for fulminant emergency ulcerative colitis. While in elective case of ulcerative colitis, where surgical intervention is mandatory by now, you will do, yes, band proctocolectomy. The patient who have cancer in their rectum, he will have a colorectal anastomosis after removal of this cancer. We have to relieve the pressure over this anastomosis to make it success. If we want this anastomosis to succeed and pass, we have to relieve the pressure of the stool from this opening. So we will take the stool up from the ileum through an opening through the skin. Because if we take it through an endoileostomy or endocolostomy, it will be hard to reverse. While the loop ileostomy, it will be easier to reverse, because the loop ileostomy is just taking half of the circumference of the ileum. While when we take endoileostomy or endocolostomy, it will be draining, right? But when we are going to reverse, it will be a larger operation. And any colonic anastomosis might require the functioning ileostomy. So what are we thinking about when we are going to do endocolostomy again? So in colorectal anastomosis, better to do, yes, loop ileostomy. I never memorized which stoma for which lesion, because you have to think, why I need this stoma? I will need it permanent or temporarily. Is it functioning or defunctioning, this ileostomy? Is it to relieve or to solve the problem? Is it the solution or co-solution? This will be your key to understand the stomas. You have to ask yourself another question. Will I have to reverse this stoma? And what part of the colon or the ileum left for me to use it? Of course, if you have removed all the colon, you will be having only the ileum. Is it emergent situation or is it elective situation? Can I anastomose the ileum at this situation? Can I use a colon when I have resected all the colon? Of course not. So why the puzzle regarding the stomas? Just take your favorite drink and think it lightly. With time you will do it perfect. Just know why are you doing this, and you will go through it. By now you are allowed to think. By the exam day you are not going to think. You will do it just right now. You will do D, C. You will choose your choice, because you have been thinking all along before, and by now you will not have time to think. Remember that octreotide is a very useful agent in reducing the output from pancreatic fistula, while the prokinetic agent will increase the fistula output and should be avoided. Again, in pancreatic fistula, use the octreotide, but never use the prokinetic agent. A mesh is a very revolutionary option for preventing the abdominal wall hernia. However, a very famous question about obese patient came with ileus for major abdominal surgery like rupture abdominal aortic aneurysm, or even after strangulated hernia. He is at risk of intra-abdominal compartmental syndrome, and the risk will be increased by the usage of the prosthetic mesh. So please don't use the prosthetic mesh in emergency situation. Again, don't use the prosthetic mesh in emergent situation, or in elective cases, prepare your patient for the intra-abdominal pressure will be used after this mesh. He might die. Regarding the abdominal compartmental syndrome, intra-abdominal pressure is steady-state pressure concealed within the abdominal cavity. In adult, the normal intra-abdominal pressure will be from 5 to 7 millimeter mercury, and in abdominal hypertension, it will be from 12 to 25 millimeter mercury. Any changes above 15 millimeter mercury will be associated with microvascular hypoperfusion of the organs, so take care. That's why during laparoscopic surgery we inflate the abdomen with carbon dioxide gas because it can be absorbed and below 15 millimeter mercury. Abdominal compartmental syndrome is defined as sustained persistent intra-abdominal pressure above 20 millimeter mercury coupled with new organ dysfunction or failure. It may occur either primarily without previous surgical intervention, like following intestinal ischemia, or secondarily following surgical procedure. The diagnosis is typically made by transvesical pressure measurement coupled with index of the clinical suspicion. Please, it's a clinical finding. Abdominal compartmental syndrome must be in your head. Once the diagnosis is made, non-operative measurement should be instituted, like gastric decompression, and improve the abdominal wall compliance, like muscle relaxant and sedation. Please, he is a human being. Give him a sedation and relaxant. Drain the abdomen of any fluid collection intra-abdominally, and consider fluid resuscitation and diuretic if clinically indicated. In those whom non-operative measurement is failing, the corrective treatment will be laparotomy and laparostomy. And the option for laparostomy may also the Bogota bag or bag technique and have a secondary look. It's a serious complication. It's a serious condition. Prevent your patient from the intra-abdominal compartmental syndrome. Remember some important signs with their names and their affiliated organ. The Robson sign for appendicitis, and the Poix and Murphy sign for cholecystitis, while the Cullen sign is very famous with the pancreatitis or intra-abdominal hemorrhage, and the Gray-Turner sign with the pancreatitis as well, and retroperitoneal hemorrhage. And remember, pancreatitis is a retroperitoneal organ. In clinical practice, hemorrhagic pancreatitis is thankfully rare. In case you forget, the neural response before the hormonal response. The hormonal response is late but lasts long. So hormonal, late but lasts long. Neuro, early with short time. So remember that the first branch of the external carotid is the superior thyroid, while the first branch of the internal carotid is the ophthalmic artery. And remember, there is no branch for the internal carotid in the neck because it's a pure intracranial artery. Acute appendicitis is a clinical diagnosis, yet it's a clinical suspicion until proven intraoperatively. There is no proof for acute appendicitis except intraoperatively. No matter we say it's a clinical diagnosis, it's a high suspicious diagnosis, but confirmed intraoperatively. So, when you are using the laparoscopic, it's diagnostic and therapeutic. You will be visualizing the whole pelvic cavity. You can visualize the whole organs, especially in females, the ovary, the fallopian tube, and even the ureters and the colon, the ileum. Anything can be visualized with your own eyes, not just your hand through a narrow space in the open appendectomy. So, in laparoscopic surgery, you can visualize the whole abdomen and explore it and know what is the exact pathology in there. It's a clinical diagnosis with high suspicion, proved only intraoperatively. That's what you are telling your patient. It's a highly suggestive appendicitis pain. and will be proved intraoperatively. Regarding the diagnosis of mesenteric infarction, old age with bloody diarrhea and pain out of proportion of the physical signs. And when you check his vitals, you will find AF in his vital section with generalized abdominal pain. This suggests mesenteric infarction. Again, old age, AF, bloody diarrhea, generalized abdominal pain out of proportion of the physical sign. This suggests mesenteric infarction. Liechtenstein repair in the open hernia repair, the onlay over the fascia transversalis with the proly mesh. It's for giving the mobility of the cord and strengthens the posterior wall of the fascia transversalis behind the spermatic cord, because if the mesh over the cord, it will limit the motion of the cord and it will not be adherent to the fascia transversalis, as you see, because there will be a space occupied by the cord. The cord must be freely mobile over the mesh. It's very important for many things in male. So, if the mesh over the cord will create a space which will weaken the posterior wall, which as if we didn't do anything with our mesh, so the mesh must be adherent to the fascia transversalis. And by the way, the sublay mesh is better than the onlay mesh. That's why there is no need for the mesh to be over the cord, but if we can put it adherent to the peritoneum, it will be more and more useful for the patient, because the problem in the weakness in the transversalis muscle and fascia. If you have a diffuse abdominal pain, it's a relieving sign. It might be just an irritable bowel syndrome or a heavy meal or just colics. But if you have a very specific localized pain, it will be an alarming sign. You have to look. If it's right hypochondrial pain, it might be acute cholecystitis. If it's right inguinal pain, it might be, yes, appendicitis or ectopic pregnancy or whatever you are searching for. So take care for the 9 quadrants of the abdomen. Localized pain is an alarming sign. Radial nerve. It's nerve route from C5 to T1. The sensory innervation. Take care. It innervates most of the skin of the posterior forearm. Yes, surprise, it innervates most of the skin of the posterior forearm and the lateral aspect of the dorsum of the hand and the dorsal surface of the lateral 3.5 digit. But take care, it's almost always masked by the ulnar and median nerve innervation. That's why the deficit is only a coin near the snuff box in the dorsum of the hand if radial nerve injury occurred. But this doesn't mean that the radial nerve innervation is only this coin, but the sensory innervation is to the skin of the posterior of the forearm and the lateral aspect of the dorsum of the hand and the dorsal surface of the 3.5 digit and masked by the ulnar and median nerve. And of course, the motor innervation of the tricep brachii and the extensor muscle of the forearm. Take care. Take care. Regarding the colostomy and ileostomy and the stoma, don't confuse lobe ileostomy and lobe colostomy. A lobe colostomy is the only safe option for obstructive rectal cancer, and it's used also in the emergency situation for relieving of IO fastly in a toxic patient. While the lobe ileostomy in the context of the rectal cancer is performed as the effect to mitigate the effect of the anastomotic leak following a low anterior section. If you have done colorectal anastomosis, you will have to do lobe ileostomy as a defunctioning ileostomy to relieve the pressure over the anastomosis you have done. So, as a rule, the large bowel obstruction result from carcinoma should be resected or stented or defunctioned. The function fastly in obstruction means lobe colostomy. It's more fast than lobe ileostomy. And this is the function of the lobe colostomy, which has a very limited situation to be used. A history of weight loss and intermittent diarrhea in a young patient makes inflammatory bowel disease the most likely diagnosis. Conditions such as appendicitis and infections have much shorter history. Although MCLs can bleed and cause inflammation, they seldom cause marked weight loss. Care mesenteric infarction, the pain will be out of proportion and the patient will be AF in the vital signs and will come to you with bloody diarrhea, in old patient of course. Hypotension and tachycardia with back pain in a patient who is collapsing, please. Old patient, think for, yes, ruptured abdominal aortic aneurysm. By the way, take care, the anterior ruptured abdominal aortic aneurysm won't survive to the hospital and will die on the spot. So, when he comes to you alive, try to keep him alive. He might want an immediate laparotomy to be saved. Most of the hernias are treated with open technique, except for if bilateral inguinal hernias or recurrent previous open repair failed. So, if we have bilateral hernia or recurrence of a previous open repair of inguinal hernia, go for laparoscopic hernia. Take care. Mesenteric cyst may be associated with intra-abdominal catastrophes. Where they occur, they are typically either as intestinal volvulus or intestinal infarction, or they may pass without even noticed and discovered accidentally during abdominal surgery. But take care, they seldom cause intussusception. Again, mesenteric cyst seldom cause for intussusception, rarely cause intussusception. When we are mentioning the mesenteric cyst, we have to mention the Tilo Triad. The Tilo Triad is named after the French surgeon Paul Tilo and can be seen in cases of mesenteric cyst as the following. We have Tilo Triad, so it's 3 items. First, fluctuating swelling near the umbilicus. 2. Free mobile in the direction perpendicular to the attachment of the mesentery. 3. With a zone of resonance around the swelling. So again, fluctuating swelling near the umbilicus, free mobile perpendicular to the attachment of the mesentery, and with a zone of resonance around the swelling. This is the Tilo Triad for the mesenteric cyst. Take care, in Hartmann procedure, the sigmoid colon is removed and an endocolostomy is fashioned. And though it has the least cause to cause a malabsorption, Hartmann procedure, the bowel will remain in continuity and no absorptive ability is lost. While take care, in ileocolic bypass, it may cause malabsorption. How is that? Because a redundant lobe of a small bowel is in continuity, yes, but the content will stagnate and bacterial overgrowth will occur. Therefore, it is a recognized cause for malabsorption. This is the ileocolic bypass. In an old patient above 50, how you can consider a right iliac fossa pain to be an appendicitis? Of course, you have to exclude malignancy first. And to exclude malignancy, please run out your investigations. And the exam will give you some clues regarding anemia, and the hemoglobin will be falling. So how come appendicitis to be causing a falling in hemoglobin? He is giving you many clues, even if the age only is your own clue in the cases of right iliac fossa pain. If he is a young patient, younger than 50 or above 50, please go for exclusion of a tumor in right iliac fossa pain. As a rule, appendicitis is not the first option in the extreme of ages. The 5-HT3 antagonist is the hydroxytryptamine 5 antagonist. It's a type of serotonin and used as a chemoreceptor trigger zone targeting for anti-emetic drug effect. It has many other uses, by the way. From the 5-HT3 procar family, the ondansetron. So, ondansetron, it's an anti-emetic drug which targets the chemoreceptor zone at the area of the postrema. The vomiting center is in a part of the medulla oblongata and triggered by the receptors in several locations, like the labyrinthine receptor of the ear, motion sickness, and over the distension receptor of the duodenum and the stomach, and the trigger zone of the CNS, like many drugs of the opiate acts here in the trigger zone of the CNS, and the touch receptor in the throat, which can cause the gagging reflex. Again, labyrinthine over the ear and distension at the duodenum and stomach, trigger zone the CNS, and touch receptor of the throat. All of these receptors triggering the vomiting center in the medulla oblongata. By definition, in case if you have asked in the exam, it's a reflex of oral expulsion of the gastric and sometimes the intestinal content by reversing the peristaltic movement and abdominal contraction. We all agree that for doing appendectomy, the laparoscopy is more diagnostic and more therapeutic, more cosmetic. The best in females will be laparoscopic. And if you have to use the open technique and to choose between the gridiron and the lens incision will be superior and cosmetic, while the gridiron is more exploratory, but the lens is more with the larger line of the body and will give more cosmesis for the females. We want this female to be married. Please. Psoas abscess. Psoas abscess is a very challenging case, and it might be either primary or secondary. The primary cases often occur in the immunocompromised patient and may occur as a result of hematogenous spread, while the secondary cases of the psoas abscess may occur as a complication of intra-abdominal disease such as Crohn's disease. So, psoas abscess patient usually present with low back pain, and if the abscess is extensive, as a mass effect might occur, and it can be localized to the inguinal region of the femoral triangle. Smaller collection may be percutaneously drained. If the collection is larger or percutaneous route fails, then surgery via a retroperitoneal approach should be performed. Remember, burst abdomen or abdominal wall wound dehiscence is a very serious problem and is expected to happen in the first 6 days by the red sign when the red seroma is appearing out of the wound. You have to be aware that this red sign is an alarming sign for wound dehiscence, and this will occur before the 6th day after suturing this wound. And from the techniques that decrease the wound dehiscence is the Jenkins rule. If you are not following the Jenkins rule in closure of the abdomen, it might occur. Of course, there are many causes for wound dehiscence, general factors and local factors. Of course, you know most of them, like general factor for malnutrition and vitamin deficiency, jaundice, steroid uses, a major wound contamination, and uncontrolled diabetes or immunocompromised patient. This may cause as general cause for wound dehiscence, and local cause for the wound faulty technique or even infection. This might cause a wound dehiscence, so take care. It occurs in the 5th day or before the 6th day, and can be prevented by just observing the wound closely and knowing that the red sign with the red seroma appearing from the wound is an alarming sign for wound dehiscence. Jenkins rule for abdominal wall closure. This will decrease the incidence of wound dehiscence, where the length of the incision increases to a variable length up to 30% in post-operative period. If the length of the suture is not able to accommodate this stretch, it will cut through the fascia. So use 4:1 suture length, where the suture length have to be 4 times the incision length by a ratio of 4:1. It will take adequate bite and avoid cutting through the fascial sheath. And sutures could be placed 1 centimeter away from the fascial edge and 1 centimeter away from each other. So each suture is away from the other suture 1 centimeter and away from the edge 1 centimeter. Again, the suture length will be 4 times the suture line. So if you have a wound about 5 centimeter, you have to have your suture length about 4 times this 5 centimeters. So 4 by 5, it's with 20 centimeters. Of course, the abdominal wall will be at least 30 centimeters. So you have to be using at least 4 times, so about 30 multiplied by 4, about 120 centimeter length, the suture length. And the suture will be placed 1 centimeter away from the fascial edge and 1 centimeter away from each other to maintain the Jenkins rule. The rooftop or chevron modification incision. The incision is below the costal margin, along the whole costal margin, bilateral, in continuity, yes. The incision may be continued across the midline into double cohar incision or rooftop appearance, which provide excellent access to the upper abdominal, particularly in those with broad costal margin. It's used in total gastrectomy or total oesophageectomy and extensive hepatic resection or bilateral adrenalectomy, and even can be used in some access for the pancreas for resection surgery if required. Microscopic colitis is a very challenging case because however, it's a common condition which is characterized by a normal endoscopic appearance and microscopic features of colonic inflammation and thickening of the subepithelial collagen layer. The features such as granulomas will be absent. So we can roughly say that microscopic colitis is a histopathological diagnosis. It's not diagnosis with the endoscopy, it's by histopathology. That's why it's challenging, because the normal appearance of the endoscopy makes this challenging and will be a diagnosis of exclusion. Definition: a CT scan demonstrating a hernia lateral to the rectus muscle. What can it be except for Spiegelian hernia? Rector's hernia. Rector's hernia is a condition when a part of the wall of the small bowel, not the whole circumference, but the anti-mesenteric border, part of the circumference will be strangulated hernia. This is the rector's hernia. Remember that the umbilical hernia is confined to the umbilicus and will take the whole circumference. There will be no crescent, and if you have seen crescent or the question mean to mention a crescent appear, so it's not congenital, it will be para-umbilical hernia of the adulthood, not the childhood, because umbilical hernia is congenital and will not be crescent appearing except for the para-umbilical had the crescent. And the para-umbilical hernia will be managed surgically because it's more liable for strangulation, unlike the umbilical hernia, which is less liable and will wait for the 2-year-old. It will be spontaneously resolving if less than 2 centimeters. If larger than 2 centimeters, we have to go for herniotomy in children. Lateral hernia is a hernia containing mecal diverticulum, while amnion hernia is a hernia that containing appendix. Yes, amnion hernia, appendix, lateral hernia, mecals.